Right. A very good morning, all of you. So today is Ritika's mother's birthday. So Ritika, do convey our birthday wishes to your mother, and I'm sure you're having tasty and yummy foods. Not just Ritika, but everyone. I see many of you giving variety of food names, which is really hard to imagine given the lockdown situation we are in. So we'll start our today's discussion with case-based discussions as you requested yesterday. So we'll have a context and then we'll discuss related questions pertaining to the same and see to that you're maintaining notes simultaneously. Okay, so let's proceed. So as you can see, a 35-year-old man comes to your clinic for routine dental examination. IOPA in relation to 4.4 reveals a radiolucent area along the lateral surface of the root. No clinical signs or symptoms associated with the patient, and also the associated tooth is vital. So what's your diagnosis? I'll show you some radiographic images and you can simultaneously go through the question. So as you can see, this is the scenario. So in relation to 4.4 distal aspect, you can find radiolucency. As I mentioned, the tooth is vital. Patient has no symptoms. Also clinically, there are no signs. So no signs and symptoms. Tooth is vital, and you can see a well-defined circumscribed radiolucency along the lateral aspect of the premolar's root and asymptomatic, as we discussed. So what could be your diagnosis? So let's look into the options. Lateral periodontal abscess, periapical cyst, lateral periodontal cyst, mental foramen. So which one do you think is more appropriate answer? It's quite obvious, right? Wonderful. Lateral periodontal cyst. Okay, so let's continue with our next related question. So it cannot be an abscess because if it's an abscess, even this particular radiolucency might be an abscess. But what about clinical signs and symptoms? So obviously there could be some drainage, or even though there could be some changes in mucosa clinically. So we can rule out abscess. Mental foramen, that's not the location of mental foramen. It will be present more periapically. And also, what about periapical cyst? So the location itself is obvious, right? So based on the given context, it's obvious that it's a case of lateral periodontal cyst. Very good. Now, coming to a related question, botryoid odontogenic cyst can be differentiated from lateral periodontal cyst. In fact, Weathers and another scientist have reported these cases of botryoid odontogenic cyst way back in 1973, and they found out this particular lesion to be very much similar and to that of lateral periodontal cyst. So botryoid odontogenic cyst can be differentiated from lateral periodontal cyst through which of the following names? Clinical, radiographic, histologic, all of the above, or none of the above. So how would you differentiate lateral periodontal cyst from botryoid odontogenic cyst? Purvi says histologically, Neha says radiographically. And if one of you say clinically, then that completes the answer. Okay, well tried. So it's not just radiographically. Botryoid odontogenic cyst can be differentiated from lateral periodontal cyst histologically as well as clinically. Histologically as well as clinically. Now, I'll show you some radiographic images. Let's evaluate them. Do go through them very carefully because we have some related questions as well. So as I have shown you initially, this is a case of lateral periodontal cyst. So you can clearly make out a circumscribed area and maybe a thin radiopaque periphery as well, isn't it? So along the lateral surface of the root. Even this is a case of lateral periodontal cyst, where you can see a conspicuous radiopaque border. I mean, if you can carefully observe, there is a radiopaque border. And also the lesion seems to be fairly circumscribed. And this is also another case of lateral periodontal cyst. Remember, when I say the tooth is vital, it's in this case the tooth is vital, but sometimes even the tooth can get involved and it might turn non-vital, right? Who knows? So I have to examine carefully clinically. So this is also a case of lateral periodontal cyst. So another case of lateral periodontal cyst. Usually you can see the diameter to be around 1 centimeter or even more than that in some cases. What about this? This is a case of botryoid odontogenic cyst, which we are discussing now. As you can see, it's a polycystic variant, and you can see multilocular appearance, right? So multilocular appearance. So radiographically, botryoid odontogenic cyst can be differentiated from lateral periodontal cyst through multilocular appearance. Even histologically, you'll find multilocular appearance. Even clinically, upon extraction of tooth or upon removal of this cyst, you'll find multilocular appearance, as stated by Weathers and all, way back in 1973. And also many of them came up with case reports pertaining to the same. So to add some additional information pertaining to this, yeah, all is right answer. Lateral periodontal cyst is usually seen in the age group of around, the mean age is 50 years, but the age range is 20 to 80 years. And it's mostly associated with mandibular, bicuspid, canine, and incisor area. Two-thirds of the cases. One-third of the cases were also found in maxillary lateral incisor areas. And this lateral periodontal cyst is of developmental in origin, known to arise either from cell rests of Malacés or other odontogenic rests. So consider this very, very important. Okay. Now, since we have discussed these two questions, let's move on to the third question. Your treatment plan in this particular case, because you diagnosed that to be your lateral periodontal cyst. So what would be your treatment plan? Root canal treatment followed by scaling and root planing, root canal treatment followed by curettage of periodontal tissue, extraction of tooth. Seems obvious, right? What about surgical enucleation? So which among the following would you rather prefer in this particular case? And I've shown you the radiograph initially as well. I see some of you saying B. See, why do you go for root canal when this case is mentioned to be vital? If the tooth is vital, there is no necessity to involve the endodontic aspect, right? So you can rule out that. So I said if in certain cases if the cyst gets infected or there are cases where the tooth turns out to be non-vital, that's the case. Obviously, we go for root canal treatment, no doubt in it. But in this particular context, we discussed that there are no clinical signs and symptoms and the tooth is vital. So would you prefer root canal treatment? Obviously, no. Good. So whenever possible, the tooth has to be preserved as much as possible. But if that's not the case, then it has to be extracted. However, the first preference would be surgical enucleation of the cyst, removal of cystic contents along with cystic lining, right? Surgical enucleation. That's very, very important. That's in case of lateral periodontal cyst. If it is botryoid odontogenic cyst, it is known to be more recurrent and persistent. So you remove the cyst and you try to carefully observe the case periodically with regular checkups or follow-ups. Okay, so that's the only relevant information for you. Now, coming to the next question, the radiopaque border of the cyst. You have seen several radiographic images. You've seen that there is a radiopaque border. So it obviously represents a sclerotic bone. And the radiopaque border of the cyst can be explained. So not just in this case, but in any case, in any cystic lesion or expansile lesion, you find a radiopaque border, but the center appears to be radiolucent. So how do you explain that? Slope rule, eggshell effect, overexposure of radiographs, none of the above. So which one of the following explains the radiopaque periphery of any particular lesion? I see some of you choosing none. Okay. What about overexposure of radiographs and slope rule? Slope rule can be ruled out because it's known to detect the relative position of a particular lesion or object of choice. So Clark's rule or Slope's rule can be ruled out. What about eggshell effect? As most of you rightly mentioned, eggshell effect explains the following. So I'm quite sure you're familiar with this concept. Let's briefly look into the same. So in this particular image, you can see the egg, right? See, the egg contains a shell which is uniform in thickness all over. But surprisingly, you can find the radio opacity only along the periphery. Why is that? Because as you know, and as you can see, the photons or the X-ray photons which are traveling along the periphery of the egg, they have to travel through more amount of the shell. So they are more attenuated compared to the X-ray photons which are traveling at right angles to the egg, where the X-ray photons which are traveling at right angles have to traverse only through little amount of eggshell. But those which are traveling tangentially or along the periphery of the egg have to be traveling more through more amount of eggshell. So as a consequence, these X-ray photons are attenuated to a greater extent compared to these. And that's the reason why you have this peripheral eggshell effect, right? It's very simple to understand. And also you can see a case of expansor lesion with a peripheral radio opacity, right? So the radiopaque border of the cyst can be explained by eggshell effect, would be the more appropriate answer. Wonderful. Now let's move on to the final question. If the cyst becomes infected, let's suppose this is a case, the cyst has become infected. So obviously when it gets infected, there can be pus drainage, and so the body tends to drain off infection through least resistant area, as you're all aware of. So if the cyst becomes infected, it may establish drainage through any soft tissue. That's evident over there, even through gingival sulcus. If that's the case, and also clinically sinus opening is evident, let's suppose sinus opening is also evident, which size gutta percha can you use to trace the sinus? So, we do something called as GP tracing. So which size gutta percha would you use in order to trace the sinus and take a radiograph and try to, explore its origin? So that's the question for you. So consider this as your homework. And if you know, you can answer it now, or else you can refer and get back through mail. Okay. So before I summarize, before I conclude, let me summarize all that we have discussed so far. I see many of you attending live now. So as we have started with this particular context, a 35-year-old man comes to your clinic for routine dental examination. IOPA reveals radiolucent area along the lateral surface of the root with no clinical signs or symptoms. Associated tooth is vital. So consider these as your keywords. No clinical signs and symptoms, vitality, and radiolucency along the lateral surface of the root. So when you get the keywords, right, then obviously you can answer any question with these. So I'll show you all the images at the end of the session once again. So it's a case of lateral periodontal cyst. So usually seen in the main age group of 50 years with slight male predilection. And most commonly, the cases have been reported in mandibular, bicuspid, canine, and incisor area. And this, along with botryoid odontogenic cyst, appear to be very similar. By the way, what does the term botryoid mean? So you can even consider this as your second homework question along with this GP question. What does the term botryoid mean? Why is it called botryoid? So botryoid odontogenic cyst can be differentiated from lateral periodontal cyst by its multilocular appearance, polycystic appearance, clinically, histologically, as well as radiographically. And then your treatment plan includes, obviously, tooth is vital. Your focus is on removing or excising the lesion, then you'll go for surgical enucleation. So obviously, if the tooth is in vitality is affected, then you go for root canal treatment. Otherwise, surgical enucleation, removal of cystic lining along with cystic contents. And what about recurrence? So lateral periodontal cyst, unilocular, no recurrence, but it's clearly mentioned in literature that botryoid odontogenic cyst has a higher chance of recurrence or persistence. So follow-up is very much important. And the radiopaque border of any cyst, for that matter, can be explained by the eggshell effect, where the photons traveling along the tangent or the periphery. So assume that this is your egg, and the photons which are traveling tangentially along the periphery have to cross through more amount of shell material. So obviously they are more attenuated compared to those which travel at right angles. Hence, the periphery appears more radio opaque, as you guys are all aware of. And finally, which GP cone? What's the size of GP cone that you would rather use in order to trace the sinus? right? Sinus tracing. So consider that as your homework, and also what does the term botryoid mean? So I hope it's clear. And you have any further questions or you need any further assistance, you can always get back through mail at proudtobedentist@gmail.com. And also, we're launching a new batch, short-term batch. I'm sure you might have seen the video, which I posted yesterday. And for any further details, you can get back through mail 24/7. So wish you all the best. Happy Sunday. Enjoy your brunch. And I'll see you again most probably next week. We'll come up with a new schedule. Take care.